Hello, this is Sam Simon, also known as Dementia Man, for the blog for the week of January 25th. I think I got that right. And you may be confused, it's a different background. And indeed, welcome to my study. I'm not sure the people who, those of you who have watched these podcasts have noticed that this is where I really live, so to speak. Joining us again is my cognitive navigator, Susan, who you have met. But our special guest today is Beverly Thorn. And Beverly is also an author. And Beverly, you are coming to us from, and we want to talk about her book. Um, but we're also going to talk about a little bit about how we came to meet each other.
Okay.
And I think it's important because it is one of the perhaps most, I don't want to call it, I think, complicated part of this journey to a degree. And that is, she saw me interviewed by Dr. Mark Rothman, who you may have seen his interview me. And I did say something which I'll even admit I'm going to stand corrected on a little bit. But we talked about end of life choices and my views. So I think our listeners are aware about it. And so Beverly and I had that sort of triggered our introduction with each other. I want to jump up here. I had it up as well. While we're talking, well, I want to make sure we make that people know how to get your book, and which is probably the same place you can get mine on Amazon and Noble, Barnes and Noble, and all the rest. But I'm blanking on the name of your book. So say hello and tell us the name of your book.
The name of the book is Before I Lose My Own Mind, Navigating Life as a Dementia Caregiver. And yes, you can get it on Amazon, Barnes and Noble. You can order it from your favorite local bookstore. And you can also get it, all those links on my website, drbeverlythorn.com. And I mention that and I really promote the website because as we talk about the book and talk about all the resources in the book, they're all on the website, freely downloadable.
Well, and you know something, we'll begin at the end. Now, this is of the end. I've been there and I've been on the book. I mean, and if you order the book on Kindle, the links are live in the book. Um,
Yes.
those resources are fabulous. I think, just to start in a little way, and then I want to talk about your book. Um, Susan and I, when we got started, fell into a dark hole. Um, we did not have experience. I think this is different for you. In our family, in our life, there wasn't, and neither side of the family did we see Alzheimer's or serious neurocognitive disorders. I hate the word dementia. Well,
Mhm.
uh, and so we really didn't have a serious personal experience, even in the community, not just that much. And then, the process of getting diagnosed and then getting the moment it's in the play and in the book, my book of getting told you have um, Alzheimer's. And I love that you have, first of all, you've had family experience beyond
Yes.
you and your husband.
Yes.
And the one thing we could have used so much more were, it was a book like yours. And my book is a little different because I have resources and I mention them, but it's mainly an argument of sorts about finding ways to live meaningfully, which
Mhm.
yours does too, but it's different. So I really encourage people to get your book, particularly if they're beginning to see it in their lives. And when I say that, it doesn't have to be you or even in your household.
Right.
It can
Right.
be your community.
Right.
Um, and want to get a little bit more information, want to know where to go. Um, it's lovely that at the end, I'm going to talk about the end of each chapter are the resources and the like.
Yes.
So tell us a little bit, sort of the start of your normal book. Talk of why did you write this thing? What happened?
Oh, well, let me pull the book forward too so people can see the wonderful cover because one of my dear friends actually took the photograph for the cover,
Oh, look at that.
and that made it even more special. Um, so what happened was I had a 36-year career as a professor of psychology and in clinical health psychology, an area that looks that helps people either maintain their health or try to recover from particularly chronic illnesses and use behavioral approaches for that. And so I worked with people with chronic pain and people with chronic illness for a long time. And then my husband started experiencing difficulties. And I realized when he was diagnosed with Alzheimer's disease, not dementia, with Alzheimer's disease and mild cognitive impairment, that I was going to be helping him and myself cope with a chronic illness that lasts until death because um, degenerative cognitive impairments are life limiting. And so I had not been quite that up close and personal. My stepfather had Alzheimer's dementia. My mother had uh, vascular dementia, and my mother-in-law had some sort of dementia. So I was familiar with neurocognitive problems. Actually, my brother had Parkinson's, so I was familiar with neurocognitive problems, but I hadn't lived with it, and living with it is quite different, is quite different. So I had to tutor myself up, and I certainly did. I knew a lot about the brain to begin with because I was dual trained in clinical psychology and neuroscience. But I had to tutor myself up, and I wanted to tutor myself up because I wanted to be the best, most informed caregiver that I could be. And in the process, I started posting on dementia support groups, and people were saying, I just printed this out and put it above my desk because it's so useful to me. And people were encouraging me to write another book. I have professional books. And I thought that's the last thing I need during this time. But after my husband passed in 2020, after a recovery period, I started taking out my journals because I did journal for stress management. And I thought, do I have a book in me? And I decided I might. So I started writing and it was published in May of 2025.
So it took 5 years, all right, from he passed in
Yes.
2020.
Yes.
So I've written a couple of books. You can see some of them back there. The other one called The Actual Dance
Hmm.
um, was similar. I wrote, so I'm was diagnosed in 2022, and I wrote this in 2025.
Hmm.
But Susan, in the 2000, early 2000s, was diagnosed with breast cancer, and I had been pulled aside by the doctors to say she wasn't going to survive.
Yeah.
And by the time they decided that at least that I never believed she was cured, but the 5 year mark where they sort of say, well, if it comes back, it'll be something different.
Hmm.
It took me almost 10 years before I found my way to write. I write, I don't know why I started writing plays, but then writing the book. Um, it's interesting that near loss of the loss of a loved one can generate I needed it. I needed it. I'm curious to you whether it's your view. I needed it to understand what happened to me. It's sort of a
Mm.
strange thing.
Hmm.
Um, because it's, when you're with someone you love, and again, this is one of the things that really interests me about your position and Susan's position. Is why I'm glad Susan's here. Because I have come to the conclusion that my experience as care partner, or love partner, I call it, with Susan at that moment and imagining holding her in her last breath and how traumatic that was for me is so different than the experience when the love partner, the other person becomes someone else.
Yeah.
And the challenges around, I watch, so we're in this world now, and I watch not just Susan, but other people in that position. And it feels to me a magnitude of order more challenging
Hmm.
um, than, you know, to jump. Already, Susan and I found the need to speak to a social worker about my
Hmm.
behaviors and
Hmm.
how they are impacting her. Not that I necessarily, like a normal person, can just, oh, I'm doing that wrong, I'll fix it. But
Hmm.
at least I'm more aware. But she was actually afraid to tell it to my face.
Uh,
She she needed, I didn't know that until she told me, even after we talked to the social worker. It was a Zoom, that's why I keep going like that. But
uh,
anyway,
uh,
so I'm so glad that you've written this. And that, uh, I don't tell us, I saw that your organization, it's chaptered, it's each piece of it. But I wonder
mhm.
if you have some things that you might want to highlight for assuming, and I think it's true that we will have more people listening to this who are either in the caregiver role or the treatment role than
Yes.
people who themselves have Alzheimer's.
Possibly so. Yes.
And maybe some encouragement to them about, what the high levels of what to think about and um, some gems. But you and Susan could talk too.
Well, first of all, when I started to write the book, I was feeling like I really had something to say to the folks that have the caregiving duties for someone with neurocognitive impairment. And I wanted to bare my soul and share my soul because one of the things that people consistently say about caregiving, and I believe in particular dementia caregiving, is that they feel so alone. And there is actually a quote that when you say you have Alzheimer's, the world leaves you and
Hmm.
leaves your caregiver. And there is a certain stigma about dementia and about Alzheimer's, and people are frightened of it. They're more frightened of dementia than heart disease or cancer. They're more frightened of that. And even though we know that neurocognitive impairment is not catchy, um, people are uncomfortable, particularly with the behavioral changes that come about. So I wanted to share that you, the reader, probably are feeling alone, but you're not alone. You feel alone, but you're not alone. And I wanted to write the book to make people feel less alone.
Yeah.
And to do that, I think you need to share facts. And so there's a lot of facts in the book. Also, your personal journey. And the book is my personal account of how Walt and I traveled this road together right through his death. And then the last third of the book really is after his death about my grief and recovery and rebuilding of my life. So the first third is about pre-diagnosis, diagnosis, and early stage cognitive impairment. And the second third is about middle, late stage, and actually his death. And I would say the second or the middle third is the most difficult for most people to travel through. And I do tell people to take it slow, even though it's a easy read, it's a quick read, it's not an easy read emotionally.
Yeah,
And then the third stage. Go ahead.
I do want to, so I think one thing that is different about Susan and I in this world a little bit uniquely is that we both had played the role of the caregiver,
Yeah.
with the other having a terminal diagnosis.
Mhm.
But what you just said reminded me, as I was performing the actual dance, the other play, and talking and written the book, I had the chance to visit at Sloan Kettering. They have a psychiatry department for associated with their breast cancer de- uh, departments.
Mhm.
And the woman, whose name I won't remember, was quite well known, and she was in her 80s. And she agreed to see me and talked about my book. And she arranged, I did perform for, or they presented it to their community. But know, she looked at me at one point and said, Sam, there's one thing you've got to know. You can never know what it would be like had she passed,
Mhm.
as she didn't. And you
Mhm.
got, and she, I mean, the intensity in her presentation, and I do, and I believe it, that
Mhm.
you can't imagine that. You cannot
Mhm.
think you know, because
No.
that's the one thing. And it's important to hear the voice, though, of that. Um,
Mhm.
so I think you offer a gift in that part of it. Again, nobody can know. It's like you also use a quote in your book of there's a saying that if you know one person with dementia, you know one
One
person.
person.
But we didn't know that other quote before. Because just real quick, I often talk about it. I'm everybody's different, so I'm not shy about it. I don't try to hide it, and indeed, I probably wear it overly on my sleeve or in my. I remember early on I was meeting with a group of people about something. Said, "Well, you need to know that I've been diagnosed with Alzheimer's disease."
Mhm.
The reaction was, "Oh my, that's so terrible. I'm so sorry." Oh, it's like, oh, wait a minute. you know, but it's reflective of your comment of how people
Mhm.
um,
Yeah.
react. And as prominent as we have been in our community, and we even have a son who's a state legislator, we're feeling isolated. In fact, one of our decisions to move into a senior living community is, we're sitting in a home in the neighborhood. We've been here 35 years in this particular house. Nobody comes by anymore. I mean,
Uh,
very, very little, very
uh,
little. And we go places, and we were involved in our synagogue and the like, but we notice it. So validating your,
sure.
yeah,
Sure. Yeah. Yeah. And that feeling of aloneness is so pervasive. That was one reason why I wanted to reach out. Um, and also not just give information and not just give my personal story, but also insights really from a psychologist's perspective, as well as all of the resources that we've talked about. At the end of each chapter, there are resources, and they're organized by section of the book on my website and by chapter and by topic. So people don't even need to buy the book if they don't want to. They can just click on the resources. Although I will tell you that people who buy the book usually buy several more copies after they've purchased one because they go, oh, my aunt needs to have this. Oh, just the other day somebody said my sister-in-law needs this, and I'm buying it for her. Yeah.
yeah. No, these are, and I don't treat that as a brag because I've had that happening with my book, which has resources not like yours, and I don't have the, I, the links are online, I think. Now, to go fix that if I um, and the resources and God, there was something else in the back of it that
The
um,
appendices.
yeah.
Yeah, there's several. My own living will and my advanced care directive, well, my living will and my dementia addendum is actually published in the book in the appendices. There's also a checklist of, quick things to consider in each of the three sections, each of the three stages um, of the book that I talk about. Um, and there's some other material in the appendices that people have said were valuable. Yeah.
Susan has had much, but now you had your training, which was helpful. Um, she had her own training. She worked for
Yes,
15 years at a senior living community. She was director of admission, of marketing and admissions. So she actually worked with the families who came often with a member of the family
Mhm.
who would need, because they had memory care and they had assisted living, to know
Mhm.
whether it was right and when the time was right. So she had that experience and is doing extraordinarily well in
And
that
which is
role.
so valuable because you're going to be an informed consumer. You already are an informed consumer.
but the thing is that, as I say to other people, I say, you know what? You've seen it, but when it's someone you love and you're with them 24 hours, things change. You,
Yes, absolutely.
there are things that happen that you don't expect, that you never thought about.
Right.
And so you do need, like you're saying, someone giving advice and so forth
Yes.
to you. And what I have done is basically we have a group of people that are going through with some type of cognitive problem, their
Hmm.
husband or their wife or whatever. And
Hmm.
we meet once a month for a respite cohort meeting.
Yes,
So
great.
that way it gives us, and if something is bothering you or you have good news or whatever, it we can feel it together. So
Yes.
that helps a lot when you're talking about feeling alone. And um, but who knows as it progresses? And I've watched in the group, we've lost about three or four.
Hmm.
The wives wouldn't. I have said, does this mean this is the end of your group for me? And we say no. Yes,
Good.
you have like you were trying to do. They don't want to write a book, but they want to be there so that they can give that help.
Yeah, share that wisdom, that hard-earned wisdom and that soul wisdom. Yeah.
I
It's
love that.
it's
So,
so very, very
Mhm.
valuable. Yeah.
yeah. Yeah. And that book is it's so great that you, of course, we're reaching out beyond our immediate communities here, but the book reaches it's useful everywhere, not just in Alabama
Right.
or McLean or whatever.
Right.
But it is a hard journey. I do want to mention too, before we get to the hard topic of this discussion, uh, and my doctor, my neurologist, is convinced that my doing work like this, my having meaning and purpose, has helped me. And it's a
Absolutely.
brain disease, so the fact that you're working, there's no necessarily scientific data that I'm aware of, but he believes compared to other patients that he feels the fact that I have this energy behind a purpose is helping me along this journey. So I'm
There's
wondering,
no doubt about that. Staying socially active, intellectually active, especially complicated intellectual activities, writing, acting, directing, all of those are complicated because they're multi-stepped. There's no question that that helps preserve brain function, for sure.
it is a hard area, though, the audience, we talk about it, but it took me a while to realize that January 1st, 2026 was the first year that the baby boomers turned 80.
Mm,
And so the tsunami is on its way,
the
if not
tsunami is on
already
its way.
here, if not already.
Yes,
Uh,
yes.
but that we are, I just think that that observation to me puts a little bit of an exclamation point on the number of people going to go through as part of aging. It's, it won't always be Alzheimer's, as you said. There are a wide variety of those things.
Right.
Before we go to the hard topic, I do want to mention too, folks know this, Susan, I call my cognitive navigator.
Yes, I like that. I really like that.
And maybe that's what I'm most proud of because I don't know why it isn't something I saw anywhere else. And so far I haven't seen it, but people love it. And we were at some event and where people, it was an event around the time I would do a performance, but one of the people we didn't even know was using it in their talk as if it was a standard phrase out there.
Household term now.
Yeah, and it is. Well, I think what I like about it, by the way, I do need it. I mean, so when I perform, I have my script on page, and Susan's in the front row. And
Mhm.
I've done this 100 times, but I just did the show this past weekend at a library here. And sure enough, what's happening now, to be right on in the moment, is I know well enough that I haven't been turning the pages to keep up with it, my script as I'm going along.
Mhm.
And I said, oh my God, and I want to look down to find the note or see it. And I'm at the wrong page, but she can get me.
Mhm.
But I need it. How do you I couldn't memorize it. In fact, performing the other play, I started forgetting the lines was one of the things. But part of our conversations, again, you talk about it in your book, and even have links to some of the information,
Mhm.
is my strong belief that I need to go through the end of this. And I'm not a supporter. In fact, I do not support legalizing aid in death. Now, I want to be clear because there are different levels.
Right.
The idea of giving informed consent and ending your life, getting the informed consent and ending your life years before you might otherwise, I'm very strongly opposed to. And I'm not a big fan of uh, medical aid in dying,
Mhm.
though, and again, I would just read the part of your book, you talk about it. If death is required, so medical aid in dying allows a doctor or medical professional, but presumably a doctor, to give some sort of end of life injection or something that if it's been verified by, I think, 3 doctors usually, that within 6 weeks, you're
6 months.
6 months, sorry, 6 months. I would prefer 6 weeks. 6 months. um, that death is inevitable, which again is issue there, but you'd be eligible for that.
Not with dementia.
Oh, well, that's good to know. But the advocates would like that to include dementia.
Applicants, yes, absolutely. Applicants would like applicants who are dealing with early stage diagnosis. Some, as my husband wanted to avoid the late stages of
Yeah.
dementia. He always said, I do not want to be alive when I can no longer recognize you or the kids or myself. That was his bottom line. And when you have dementia, by the time you are within that terminal window, that 6 month terminal window, you have lost your capacity to make medical decisions and you have lost your reasoning capacity. And therefore, you are not eligible for medical aid in dying, even in the 14 states in the United States that do allow medical aid in dying. And let me just clarify something. You said the doctor gives an injection in medical aid in dying. That is euthanasia, and euthanasia
Okay.
is illegal in this country. So with medical aid in dying in all 14 states, the person has to be cognitively intact. They have to know what they're asking for. They have to repeatedly ask for it. They have to be within 6 months, an estimate by at least two physicians usually, of dying. And they have to be able to take the medication themselves. And it's
Oh,
usually a pill form that is then crushed and ingested. Mhm.
yeah. I've been reading about Switzerland. The reference has been to a drink of some sort, but either way, yeah. No, thanks for the clarifications. The Yes, and in Switzerland, I don't believe there is a requirement to be anywhere near.
Correct.
It's just a matter of, again, competence to give the informed consent and paying the
And
fee and getting there.
yes, and usually, almost always, as I understand it, serious medical illness, you do have to submit your records. Um, and as I understand it, in Switzerland, they use an injection, but the patient requesting the medical aid in dying has to push the plunger.
Hmm.
So it's set up, but it's the patient that pushes the plunger. And it's interesting that most people vastly prefer a medication that goes into the vein than having to drink something, supposedly. Yeah.
Yeah,
So,
it's interesting. So, in fact, one of the things that triggered me to write this book, though, was to read another book where someone who was diagnosed with early stage Alzheimer's
mhm,
and whose wife quoted him as saying, I don't want to die, but I don't want to keep becoming a lesser and lesser person.
mhm.
And then talked about how hard the rest of the book is, how difficult it was to make all the arrangements. Because some doctors, some psychiatrists won't give the work with the patient who wants to do that, won't certify them. And then they went to Switzerland, described what happened there.
Mhm.
Um, and it turns out not long ago, I read the obituary of somebody I knew whose information was in my phone, in my contacts, a
Mhm.
well-known political advisor to Bill Clinton way back then, had left
Mhm.
Santa Fe where he's living and went to um, Switzerland uh,
Mhm.
for diagnosis. Which his reasoning, though, was that he didn't want to be the burden to his family.
Mhm.
And I think that, I have answers to everything, end quote, except
Mhm.
to that piece of not just burden, but the financial burden of late stages um,
Yes.
can ruin families. And there's a
Can and
tragedy,
does.
and there's a tragedy in that. And you can imagine people who spend a lifetime saving and working and supporting their children and want to be able to support the grandchildren, and all of a sudden you run out of money, and then your kids are giving you money, and everything is disappearing for what? A few more months? Or I want to acknowledge that in my strong belief that I don't, we can get to that, people know that in my book, I'm a strong opponent to um, doing that. And I prefer not be available either, because I think and I'll put that out there, and I know we don't fully agree in that there's something I have to offer in my last stage. And that is that, my hope is that whatever happens to me, and there's no guarantee in any side of this,
No.
just maybe, there's one little thing about my end of life that maybe even adds a nanosecond to the cure coming earlier than it otherwise. And it may not happen, but I'm willing to do that. That's my justification for my point of view. Well, not just justification, that is my point of view. And that's my gift. I think one way we got connected here is I can get a little excited and more blunt about that than I maybe
Yes.
should. She's lovely. She's seen that happen. But it's complicated. I do want to ask you and I want to acknowledge, let me stop there for that is complicated. Go ahead, go.
Let me say this. My strong belief is that we all should have choice over our own body. And if someone wants to die with a very serious illness, or if someone wants to die, I believe that is their choice. And I believe that you would not want somebody to choose for you. Oh, let's see, it's time for you to go. I believe that we have to uphold everybody's personal choice in the matter. My husband did not want to live beyond X point, and he was willing to give up time, give up quality time to not live beyond that. And then he changed his mind. He decided after the point where he no longer really retained rational thought, but he decided he wanted to live. And that's what he did. So it's not like I said, nope, sorry, you had this ironclad dementia addendum, you're going down. No, absolutely not. And that's what I argue for is personal choice and that kind of autonomy. And we give it to some people and we don't give it to others.
So here is the perfect, interesting. So I don't, I don't know if you recall, or I read the guest editorial in the New York Times, maybe a year or longer, by they were two doctors, brothers, whose father, who had been a doctor, had communicated to them that if he ever had a neurocognitive disorder, he even said Alzheimer's, that if he didn't want to be like that, and to withhold care should he get sick. And then years pass. It's written into his his
Will?
not what do you call medical directive. And so these brothers felt bound by it. And at the time he got pneumonia. He had, I don't know if it was Alzheimer's or neurocognitive disease. He was in a memory care. He was a different person and he was happy. And he got pneumonia.
Mhm.
Should they comply with his will or with his direct medical directive? But he's happy. He's living a life now that, and they can afford it, but and he's happy.
Mhm.
Now the point of their op-ed was, here's how you should write your directive. You should not have something that's certain, but you should have a committee of sorts. Name the people who should make the decision for you, and here are your general directives or interests or goals. But the
Mhm.
final decision is left to a group of people so that they felt they couldn't, they were bound by it, and they did not treat him for a curable ailment at a point when in his life he was happy.
Mhm.
So,
And this is the big conundrum of my now self, pre-dementia, and my then self, pre-dementia, and my now self with dementia may feel two different things. And in fact, there's something that I just heard of, and that's called a Ulysses clause in a dementia addendum. And the Ulysses clause, apparently, and I haven't had a chance to really look through it enough, but the Ulysses clause is, listen, I'm going to lose my capacity for reason. I'm going to lose my capacity to make my own decisions. And I'm telling you, this whole period of time of my life where I had strong values about this and did not want to be alive, even if I'm happy, at this period of time, let's say the 2 years where, or 4 years where I've lost reasoning capacity, I don't want you to listen to that. I want you to listen to this period of time, my lifelong goals and values. And so people are now inserting that into their dementia addendum living will. And it gives, and sometimes even recording an audio or a video of it, and it gives the poor decision makers, the the people who have to make these decisions, it gives them a little bit more to go on. And um, yeah, the whole idea of treating a treatable illness to keep somebody alive who seems to be happy yet totally dependent. Um, I think you have to decide for yourself, and I think you have to have the ability to decide for yourself and to have that respected. And it's a conundrum for sure.
yeah, I, I do want to do one, and I want to make sure people will listen to this. So if we go too much
Okay.
longer, they'll.
Yeah, that's fine.
Um, and I may misheard you, but I, well, let me ask you, when you said that autonomy, would you support someone who's just a 20-year-old who says, I just don't want to do it anymore, and they're and wants to die? Do you support suicide for anyone at any age, as long as they can give informed consent?
Well, I think suicide is a tragedy, and suicide, um, in in contrast to what we are talking about, is usually impulsive and is usually out of despair. And we have treatments for those kinds of things. And there's plenty of 20-year-olds who have decided they just don't want to live anymore. They don't want the hassle. And what do? They violently commit suicide and often impulsively commit suicide. Um, I just read an article, you probably did too if you get the New York Times, about the gate now below um, the Golden Gate Bridge, not the
Oh,
gate, but the mesh wire thing
right.
that has prevented a lot of people from jumping to their deaths. There was a study about 20 years ago where the people who jumped and survived were asked, what was the first thing you thought of as you were jumping? And now these were survivors, but it's interesting. Almost to a person, they said, I thought, gosh, I hope this doesn't work.
Oh,
So the impulsiveness is something I absolutely do not condone. And deaths of despair, and violence, I absolutely do not condone. But
see,
somebody with a serious illness and who is a serious life-limiting illness, who thinks they know what is in store and they don't want treatment, they don't want life-extending medical treatment, even after they've lost decisional capacity. Yeah, I support that.
there are arguments, and I mean, there's organizations too who sort of advocate the opposite side of this by
Mhm.
arguing that the the risk of undue influence and ulterior motives are so great. And but you even almost suggested to it, even even with this disease, unless you get to the point where see, this is the well. So let me finish that thought.
Mhm.
um, that things could change, and the people, I don't know how many people were involved in your life and your decision. We're largely, we have two children, but it'll be, it's, these things are, they're, they're not, they don't have any, they're not asking me or us to do anything different. They're not trying to guide or make sure it happens. But, in many, many other times, dysfunctional families or families who want access and they,
Sure.
how to making sure the level of confidence that it is truly a autonomous, meant, understood decision. These groups argue are so unlike are so at risk that it should not be available. So
Mhm.
that's part of their argument uh,
Mhm.
with that. You know, um, and there are voices out there that suggest that there's a point where it's too expensive for society to keep people alive and take that autonomy away too by saying they shouldn't be eligible
That's
for
the other side
that
of
kind
that
of care.
coin.
For that kind of care. So I do think it's uh, complicated and on a risk basis. I'm just we have come. It's also um, a value system, and we grew up in I'm trying not to invoke any particular religious point of view, but
Mhm.
a value system where suicide is not an acceptable ethical option. And of course, people have a choice. The idea of personal autonomy, though, up to a point, I just think, and we have so many limits on it. And I do think people, there are, I, maybe we institutionalize them if they're so younger and healthy, but suicidal because they just don't think life is worthwhile. We consider them mental illness
Mhm.
usually, and we might if they become dangerous to themselves, we'll put them in an institution to prevent that.
Mhm.
I think that almost argue, and they're of legal age in theory, over 21. So I think it's really, really complicated. And I do think there is the opportunity. I'm going to let you have the last word after me. Uh, I do think there is opportunity with everyone going through it, that there may be something so just unique and different that we create the opportunity in our own demise, if you will, of being of service to finding cures in the future. And so I'll take that. Now, your turn, and we'll end with your counter argument.
I think that the suffering of somebody who doesn't have a terminal illness, who has a mental illness, and wants to commit suicide is a different animal. and usually results in violence, and it's a tragedy. But I think somebody who has a serious medical illness and there is going to be suffering on the part of the individual and on the part of the family. And they've already said ahead of time, it's the ahead of time, the planning that I think is so, so important that we don't like to think about. We don't like to do wills. We don't like to do advanced care directives, but it's so important. It was so important for me to understand what my husband's values were, what his bottom line was. Not that I was going to kill him off, but when he went into a medical emergency and he was hallucinating, he was raving, he probably had another brain bleed. He was uncontrollable. And my choice was during COVID, send him off to the emergency department. I can't go with him. He'll be strapped down to a gurney and he'll die alone. Or get some sedation going that is not meant to kill him, but is meant to quiet him so that I can keep him at home. I knew enough from his lifelong value systems to know that that's where I wanted him. I wanted him at home with me. And yes, that sedation may have hastened his death. I thought it was the right choice, and I still do think it's the right choice.
And by the way, I think you've demonstrated clearly a breadth of conditions that may emerge in this thing. And you did not just describe what I consider, the accompanied suicide where, whatever the number of years, the quote, I'll go back to the quote, I don't want to die, but I don't want to become a less and less a person. Let's all get on a plane and go to Switzerland. That I'm strongly opposed. The complication of when to stop treatment. But as I understood what you just described, and the opportunity to be with somebody as difficult as I'm sure that can be, even, because that's what I faced in my other life. I was, I don't even know the right words to say. I hallucinated a scenario that changed my life about being with the one you love. I mean, it's hard to describe without spending too much time on it, but that is a very difficult. I want to hold her hand, as I say, journey. And when to cease treatment is different than the affirmative process, where we still may, this autonomy issues where I'm not for the. But in those moments when it's best to let nature take its course in this moment, those are difficult and in some ways ecstatic. If you can do that and be with that and hold them and be with that person, and it is. I was once asked at a conference where everybody had to participate, and there was a session on last words. And I spoke to what last words. This was in the midst of or just after Susan's. I said, here's my last words. And they would be to the person I love. I'm sorry if anything I ever did hurt you. I forgive you if you think you ever hurt me, and I love you. And if we can do that and a person can hear them, and it sounds like we're not that far off, in fact.
Yeah. I hope my last word is thank you.
And that too.
Thank you.
Thank you. Now I'm going to change it. You're right. So thank you so much for being on this and your book.
Thank you.
Everybody should get your book.
Yes, definitely.
Thank you.
No,
just please go to my website. There's so many resources for you.
Really?
drbeverlythorn.com. Thorn with no E, just like the rose.
Okay. Well, thank you, Beverly. And I'm going to, again, just Thank you very